After studying this module, you shall be able to have a broad understanding of schizophrenia spectrum disorders and the symptoms. Also to understand the epidemiology of schizophrenia spectrum disorders, to develop an understanding of the causes of the disorders, and to be familiar with the current treatment options for the schizophrenia spectrum disorders, wherein we would be discussing the definition of schizophrenia spectrum disorders. The general consensus seems schizophrenia as a group of psychotic disorders characterized by distortion of thinking and perception. It includes the disturbances in thinking, speech, perception, emotion, and behavior. This definition, though widely accepted, cannot be said to be definite, and it's being continuously revised for accuracy and universality of the diagnosis and treatment. One such revision of psychotic disorders led to the conceptualization and operationalization of schizophrenia spectrum disorders. So we can define schizophrenia spectrum disorder as a term used to group together the psychotic and mental disorders or personality types, each of which contains some of the symptoms of schizophrenia, but at a less problematic or significant level. Other than schizophrenia, the disorders encompassed by the schizophrenia spectrum disorders are psychotic disorders like Schizophreniform Disorder, Schizoaffective Disorder, Brief Psychotic Disorder, Shared Psychotic Disorder, and odd personality disorders like Schizoid Personality Disorder, Schizotypal Personality Disorder, and Paranoid Personality Disorder, as well as delusional disorders. Clinical picture and diagnostic criteria. The diagnosis of schizophrenia spectrum disorder in general can be found in DSM-5, published by APA in 2013 under the chapter Schizophrenia Spectrum and Other Psychotic Disorders. According to DSM-5, schizophrenia spectrum disorders are diagnosed by keeping in mind three factors: domains, gradients, and dimensions of psychopathology. The mental disorders must represent abnormalities in one or more of the following five domains, which are delusions, hallucinations, disorganized thinking, grossly disorganized or abnormal motor behavior, and negative symptoms. While gradients include assessing the level of psychosis, number of symptoms, and duration of the psychosis to determine the severity of the disorder, wherein the dimensional assessment captures meaningful variation in the severity of the symptoms, which may help the treatment planning and prediction of the course and outcome. The manual suggests that patient must be assessed along 8 dimensions, the 5 domains described previously, as well as cognition, depression, and mania. The detailed description of symptoms. There are certain symptoms which come under the domain of schizophrenia spectrum disorder are as follows: delusions, hallucinations, disorganized thinking, abnormal motor behavior, and negative symptoms, while the dimensions may include cognition, depression, and mania. In the case of this particular disorder, cognition refers to the process of thinking which usually is slow, disorganized, and derailed for schizophrenics. They also have poor concentration, poor memory, have difficulty in integrating and expressing thoughts. Depression refers to a negative affect and an aversion to activity that affects one's thoughts, behavior, feeling, and sense of well-being. Schizophrenic patients usually have a combination of depression, negative symptoms, and impaired cognition. Mania, that refers to high arousal level where emotions are concerned. A manic patient usually alternates rapidly between the feelings of euphoria and irritability. He or she may seem enthusiastic, feeling wonderful about the world, and harboring many ideas while seeming absolutely reckless and hyperactive. Such people are also highly distracted and talkative. They usually have decreased need for sleep, sleeping only 2 to 3 hours a day, but have twice as much energy as those around them. Disorders under schizophrenia spectrum disorder, wherein we would be discussing the psychotic disorders first. Psychotic disorders are a class of psychological disorders wherein reality contact, the capacity to perceive, process, and respond to environmental stimuli in an adaptive manner is radically impaired, with the result that the person cannot meet the ordinary demands of life. Fundamentally, these disorders are characterized by abnormal thinking and perceptions. These disorders are schizoaffective disorder, wherein the individual diagnosed typically have symptoms of both schizophrenia and severe mood disorder. This makes schizoaffective disorder a kind of hybrid disorder. In other words, the person has psychotic symptoms that meet criteria for schizophrenia, but also has marked changes in mood for a substantial amount of time. Because mood disorders can be unipolar or bipolar in type, there are two subtypes of schizoaffective disorder, bipolar and unipolar subtype. It is still not entirely clear whether schizoaffective disorder is best regarded as a variant of schizophrenia or as a form of mood disorder. In general, the prognosis of these patients is somewhere between that of patients with mood disorders. DSM-4-DR states that presence of some mood disorder with symptoms of schizophrenia as major criteria for the diagnosis of this disorder. The other criteria are that the mood symptoms be present for substantial portion of the total illness time, and the individual must have delusion and hallucination for a period of 2 weeks at least in the absence of mood symptoms. Next is Schizophreniform disorder. This disorder is a kind of short-term schizophrenia. The patient has schizophrenic symptoms such as delusions, hallucinations, etc., which are typical of undifferentiated subtype schizophrenia. What makes schizophreniform disorder separate from schizophrenia is the duration of the illness. According to DSM-4-DR, the diagnosis requires symptoms of schizophrenia to be present for 1 month at least, but less than 6 months. If the psychosis persists beyond 6 months, then it is to be diagnosed as schizophrenia. Next is shared psychotic disorder. Shared psychotic disorder, also referred to over the years as shared paranoid disorder, induced psychotic disorder, and double insanity, and was first described by French psychiatrist Lezig and Falret in 1877. The disorder is characterized by the transfer of delusion from one person to another. Both persons are closely associated for a long time and typically live together in relative social isolation. The person who first has the delusion is often chronically ill and typically the influential member of the relationship. The secondary case is frequently less intelligent, more gullible, more passive, and more lacking in self-esteem than the person in the primary case. The DSM-4-DR suggests that the diagnostic criteria for this disorder are that delusion should develop in the context of a close relationship with another person, and the content of the delusion should be similar to that of the person who already has the established delusion. Next disorder is brief psychotic disorder. This disorder is exactly what its name suggests. It involves a sudden onset of psychotic symptoms or grossly disorganized or catatonic behavior. Even though there is often great emotional turmoil, the episode is usually quite brief, often lasting only a matter of days, too short to warrant a diagnosis of schizophreniform disorder. After this, the person returns to his or her former level of functioning and may never have another episode again. Brief psychotic disorder is often triggered by stress. The DSM-4-DR states that the diagnostic criteria based on the type and duration of symptoms. The patient must present one or more of the following symptoms, which are delusions, hallucinations, disorganized speech, or grossly disorganized or catatonic behavior. And the psychotic episode must last at least a day but less than a month, with an eventual return to the normal functioning. Next category we have is personality disorders. The personality disorders that classify as schizophrenia spectrum disorder, that are the cluster of personality, odd eccentric personality disorders as described by DSM-4-DR. People with odd eccentric personality disorders have some traits in common with victims of schizophrenia and delusional disorders, though they do not show the decisive break in reality that characterizes those very grave conditions. These include the paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. So out of all these, first we will be discussing the paranoid personality disorder. As the name suggests, suspicion and paranoia characterize this disorder. People with paranoid personality disorder feel suspicious of almost all people in almost all situations, usually without any reality-based evidence. They tend to see themselves as blameless, instead blaming others for their own mistakes and failures, even to the point of ascribing evil motives to others. Such people are chronically on guard, constantly expecting trickery and looking for the clues to validate their expectations, while disregarding all the evidence to the contrary. For instance, if two people are talking together in a corner, or if the mail is late, or even if the neighbors are blaring loud music at night for various reasons, the paranoid individual regards these as evidence of personal hostility. They are often preoccupied with the loyalty of friends and hence are reluctant to confide in others. They commonly bear grudges, refuse to forgive perceived insults and slights, and are quick to react with anger. They are typically hypercritical, stubborn, and controlling. Next personality disorder under this category is schizoid personality disorder. The defining characteristic of schizoid personality disorder is a severely restricted range of emotions associated with social detachment. Such individuals are unable to form social relationships and lack interest in doing so. They also show a disinterest in sexual activities. They are often distant from their families, they rarely marry, and they have no close friends. More generally, they are not very emotionally reactive, rarely experiencing strong positive or negative emotions, but rather show a generally apathetic mood. In extreme cases, emotions like joy, happiness, gaiety, and pleasure, and negative emotions like disappointment, hurt, or jealousy are not felt or expressed at all, sometimes leading to the identification of anhedonia. These deficits contribute to their appearing cold and aloof. Next personality disorder is schizotypal personality disorder. Individuals with schizotypal personality disorder manifest odd speech, behavior, thinking, and perception. But the oddity is not enough for the diagnosis of schizophrenia. For example, speech may ramble, but never to the point of actual incoherence, as is often the case with people with schizophrenia. Like schizoid personality disorder, schizotypal personalities also tend to be excessively introverted and have pervasive social and interpersonal deficits. And in addition, they also have cognitive and perceptual distortions and eccentricities in their communication and behavior. Although contact with reality is usually maintained, highly personalized and superstitious thinking is a characteristic of people with schizotypal personality. And under extreme stress, they may experience transient psychotic symptoms. They often believe that they have magical powers and may engage in magical rituals. Other cognitive perceptual problems include ideas of reference, odd speech, and paranoid beliefs. These symptoms are highly similar to those of schizophrenia, sometimes lead them to be diagnosed first as exhibiting simple or latent schizophrenia. Delusional disorders. Delusional disorders, previously known as paranoid disorder, are a particular type of mental illness wherein delusions are the persistent and fundamental abnormality. A person with delusional disorder becomes headstrong about his beliefs regardless of any opposing evidence in reality. The person may present disturbances of moods, however, this may only be a consequence of pursuing delusions. For instance, they may explode at complete stranger, but only because they suspect the stranger to be plotting against him or any other delusion. People with delusional disorders often can continue to socialize and function normally apart from their subject of their delusion, and generally do not behave in an obviously odd or bizarre manner. Furthermore, any other symptoms shown by the patient do not include the characteristic symptoms of schizophrenia, and the delusions are less bizarre than those of paranoid schizophrenia. The DSM-4 triad lists 5 categories or the types of delusional disorders. The classic and most common type is persecutory type, then come grandiose type, erotomanic type, and somatic type. Now we go through the epidemiology of schizophrenia, wherein first we discuss the prevalence. According to NIMH, the lifetime prevalence is 0.6 to 1.9%. According to DSM-4TR, the annual incidence of schizophrenia ranges from 0.5 to 5%. Schizophreniform disorder has a lifetime prevalence rate of 0.2% and 1-year prevalence rate of 0.1% has been reported. According to DSM-4-TR, the delusional disorder accounts only for 1 to 2% of all admissions to mental health facilities. The prevalence of paranoid personality disorder is 2.3% to 4.4% of the general population. The prevalence of schizoid personality disorder is 3.1% to 4.9% of the general population. Schizotypal personality disorder occurs in 0.6% to 4.6% of the general population. Gender. Schizophrenia is equally prevalent in men and women. However, there are minor differences in the onset and course of the illness. Onset is earlier in men than in women. Some studies have shown that men are more likely to be impaired by negative symptoms and that women are more likely to have better social functioning than are men prior to disease onset. Age. Schizophrenia has peak ages of 10 to 25 years for men and 25 to 35 years for women. Approximately 3 to 10% of women with schizophrenia present with disease onset after the age of 40. About 90% of the patients in the treatment of schizophrenia are between 15 to 55 years old. Schizophreniform disorder is most common in adolescents and young adults. For schizoaffective disorder, the depressive type may be more common in younger persons and the bipolar type may be more common in young adults than in older adults. The mean age of the onset of the delusional disorder is 40 years, but the range of onset runs from 18 years of age to 90s. Brief psychotic disorder occurs more often in younger patients, that is between 20 to 30 years of age, than among older patients. Birth defects. Studies have pointed to the gestational and birth complications, exposure to influenza epidemics, or maternal starvation during pregnancy. Rhesus factor incompatibility and the excess of winter births in the etiology of schizophrenia. Epidemiological data show a high incidence of schizophrenia after prenatal exposure to influenza during several epidemics of the disease. Substance abuse. This is common in schizophrenia. The lifetime prevalence of any drug is often greater than 50%. In one population-based study, the lifetime prevalence of alcohol within schizophrenia was about 40%. Cultural and geographical factors. The incidence of schizophrenia is higher for persons born in urban areas of industrialized nations. The incidence of schizophrenia in children of either one of the two parents' schizophrenia is twice as high in cities as in rural communities. This suggests that social stressors in urban settings may affect development of schizophrenia in person at risk. Brief psychotic disorders seem to be more prevalent in people from developing countries and people who have experienced disaster or major cultural change. Socio-economic status. Patients with diagnosis of schizophrenia are reported to account for 15 to 45% of homeless Americans. This points to the profound prevalence rate of schizophrenia and low socioeconomic status. For delusional disorder, the association is seen with recent immigration and low socioeconomic status. Many of the delusional patients are also married and employed. Some clinicians claim that the brief psychotic disorder is most frequently seen in patients from low socioeconomic classes. Etiology of schizophrenia. There are a host of causes of schizophrenia spectrum disorder. These causes can be divided and understood as the biological or psychosocial factors. First, we'll understand the biological perspective, wherein we first discuss the genetic factors. The schizophrenia spectrum disorders usually occur at an increased rate among the biological relatives of the patient with schizophrenia. The likelihood of the person having schizophrenia is correlated with the closeness of the relationship to an affected relative. Then we come to the biochemical factors. Dopamine hypothesis of schizophrenia posits that schizophrenia results from too much dopaminergic activity. The major line of evidence for dopamine hypothesis comes from research on the antipsychotic drug, particularly the phenothiazines. These drugs seem to act on the schizophrenic symptoms and are used in treatment. Hence, the dopamine hypothesis asserts that schizophrenia is connected to excess dopamine activity. The current hypothesis posits serotonin excess as a cause of both positive and negative symptoms in schizophrenia. Norepinephrine seems to be the cause of anhedonia, the impaired capacity for emotional gratification, and the decreased ability to experience pleasure. GABA, that's gamma aminobutyric acid, has been implicated in the pathophysiology of schizophrenia based on finding that some patients with schizophrenia have loss of GABAergic neurons in the hippocampus. Acetylcholine and nicotine play a role in regulation of neurotransmitters involved in cognition, which is impaired in schizophrenics. Neuropathology. This refers to the neuropathological basis or neural problems for schizophrenia, primarily in limbic system and the basal ganglia, including the neuropathological or neurochemical abnormalities in the cerebral cortex, the thalamus, and the brainstem. Computed tomography, that is CT scan, magnetic resonance spectroscopy, and electrophysiology studies have shown that there is reduced symmetry in the several brain areas, volume shrinkage or neuronal loss in the thalamus, and decrease of the size of the amygdala and the hippocampus in patients with schizophrenia. All these changes in the brain areas affect hunger, sexual impulses, emotional regulation, cognition, and motor coordination. Now we have psychosocial perspectives, wherein we would be discussing the psychoanalytical theories first. Sigmund Freud postulated that schizophrenia resulted from developmental fixation that occurred earlier than those culminating in the development of neurosis. These fixations produce defects in ego development, and Freud postulated that such defects contribute to the symptoms of schizophrenia. Ego disintegration in schizophrenia represents a return to the time when the ego was not yet had just begun. Because the ego affects the interpretation of reality and the control of inner drives such as sex and aggression, these ego functions are impaired. Thus, intrapsychic conflicts arising from the early fixation and the ego defects, which may have resulted from poor early object relation. These findings fuel the psychotic symptoms. Other psychodynamic theories focusing on the interpersonal withdrawal, that is an important characteristic of schizophrenia, view the disorder as a retreat from an interpersonal world that has become too stressful to deal with. Role of life stresses as a causal factor is generally accepted. Behavioristic perspective. Behaviorists basically emphasize the role of learning in acquisition of maladaptive behavior, which causes psychopathology. They do not try to account for the onset of schizophrenia, but focus on how the behavioral symptoms of different types of schizophrenia might be shaped through the process of reinforcement extinction. Modeling may also play a part in the behavioral explanation of schizophrenia, as patients in hospital may see the bizarre behavior of other patients, get rewarded with attention, and later imitate similar behaviors. Some influential theorists attribute schizophrenia to process of modeling. This does not explain how people who have never been exposed to other schizophrenics develop their behavior. Next explanation is given by cognitive perspective. Cognitive theorists see the irrational beliefs of the schizophrenia as a severe form of illogical thinking. Cognitive theorists believe that people affected with schizophrenia have attention related to defects in filtering out irrelevant stimuli. It creates overwhelming situation. The stimulus overload produces distractibility, thought disorganization, and the sense of being overwhelmed by disconnected thoughts and ideas. As one patient of schizophrenia reported, everything seems to come powering all at once. I cannot seem to keep anything out. Family dynamics. Specific family patterns may play a causative role in the development of schizophrenia. Some patients do come from dysfunctional families. It is therefore important not to overlook the pathological family behavior that can significantly increase the emotional stress, which may make the schizophrenic patient vulnerable. The double bind concept, formulated by Gregory Bateson and Donald Jackson, described the hypothetical family wherein children receive conflicting parental messages about their behavior, attitudes, and feelings. For instance, the child is told to provide cookies for his or her friends and then is chastised for giving away too many cookies to the playmates. Some evidences do indicate that people diagnosed as schizophrenic often grow up in families where communication is disordered, and where at least one parent is critical and over-controlling. Schism and skewed families was described by Theodore Lidz as a family type wherein there is prominent schism between the parents and one parent is overly close to the child of the opposite gender. This results in the dominance of one parent. These dynamics stress the tenuous adaptive capacity of the schizophrenic person. Expressed emotion describes a family type in which parents or other caregivers may behave with over-criticism, hostility, and over-involvement towards a person with schizophrenia. Many studies have indicated that in families with high level of expressed emotions, the relapse for schizophrenia is very, very high. The treatment modalities available are pharmacotherapy, electroconvulsive therapy, psychosocial therapies, psychosocial therapies where the focus is given to social skill training. Then we have cognitive behavioral therapy, family-oriented therapy, art therapy, etc. Now we come to the summary of this chapter. Schizophrenia spectrum disorder are disorders which have symptoms of schizophrenia at less problematic or significance level. The symptoms of schizophrenia spectrum disorder include delusions, hallucinations, disorganized thinking or speech, grossly disorganized or abnormal motor behavior, including catatonia and negative symptoms, along with the evaluation of cognition, depression, and mania. Schizoaffective, schizophreniform, schizoid, schizotypal, paranoid personality, brief psychotic, and shared psychotic disorder as well as delusional disorder come under the schizophrenia spectrum disorder. The treatment for schizophrenia spectrum disorder ranges from biological therapies like pharmacotherapy, ECT, psychosocial approaches like CBT, social skill training, and family-oriented therapies depending upon the type of disorder and the symptoms.